co-chairman, distinguished guests, and my dear colleagues. Good afternoon to you all. First of all, I am thankful to the organizing committee of 4th International Pediatric Conference for their hospitality and for providing me the opportunity to speak on this important topic. As we all know that burns among the children are reported to be among the most prevalent traumatic injuries around the world. Followed by road traffic accident and drowning, burn injuries are the third most common cause of mortality among children aged 5 to 14 years in the developing countries. Childhood burns place enormous socioeconomic burdens on individuals, their families, and health services. The treatment of burn due to any cause, like scald, fire, or chemical, require multidisciplinary approach because it causes significant physical and psychological sequelae. Long-term treatment and follow-up are required for rehabilitation and for regular surgical intervention. If we see the percentage of burn, severe burn injuries, almost half of them are children. The burn injuries not only causes pain and infections, but it can lead to extensive scarring, wounds, and contractures. Sometimes, in extreme cases, the result may be amputation, death, or psychological trauma. We have seen very limited data on infantile burn injuries despite large amount of international literature on pediatric burns and their causes. We are conducting several studies covering different aspects like duration of stay in relation with the degree and percentage of burns, frequency and antimicrobial sensory pattern of microorganisms isolated from hospitalized burn cases. Considering the fact that Patel Hospital Plastic Burn Surgery Center is the only specialized center in Karachi dealing with burn injuries, and it accepts referrals from all over Pakistan. So we carried out these studies. Many people are involved in this study. First of all, I would like to introduce my co-authors. The assistants and experience have me around in these studies.
Check.
Professor Jalal Akbar, he is here with me.
Check.
He's the chairman and head of Department of Pediatrics, Bakai Medical University, Karachi.
It was on the same channel. Oh, okay. Yeah, it's a Wi-Fi one, so we were together.
He's a member of Center Executive Committee, Pakistan Pediatric Association. He's also the member of Polio Eradication Committee, Government of Pakistan. Professor Gerard did a lot of work in the field of pediatrics, both at national and international level. One thing I would like to mention here, that he is not only the role model for me, but for young pediatricians. Dr. Mazhar, he's in charge of plastic surgery and burn unit. Dr. Ashad Hamid Khan, he is here with me. He also worked in this study and is also the member of Pakistan Pediatric Association. This is the front view of Patel Hospital. It's a 250-bedded hospital, provided facilities in all the clinical specialties. Accident emergency, cardiology, cardiothoracic surgery, ENT, head and neck surgery, neuromedicine, neurosurgery, gynae and obs, pediatrics medicine, pediatric surgery, and many others. In 2002, recognizing the lack of medical expertise in the area of the burn injuries in Pakistan, Patel Hospital established Pakistan's first separate 50 beds burn unit with ICU. Now, the aim of this study is to determine the incidence, causes, nature of injury. Nature of injury means percentage, degree, and the site of burn. Length of stay, outcome infants with burn. Children up to 1 year of age were included in this study. This retrospective study was carried out during a period of 7 years from January 2007 to December 2013. Total number of patients admitted were 1,862. Up to 15 years, 789, 42.4% were children, so almost half of them were children. And among this category,
106, 13.4% were infants. The burn in this age group is very painful, and sometimes it is very difficult to manage. It can be prevented by giving the education to the healthcare provider and to the parents. If we see, in 106 cases, 83, 78% were admitted because of scare burn, 20% were admitted because of fire burn, and 2% were admitted because of chemical burn. 60% of these burn occur in winter season. Mean age of admission was 7.9 months. Lowest recorded age was 21 days, and maximum age was 11 months and 20 days. If we see the causes of scare burn, most of them are kitchen items like hot water, hot tea, hot milk, hot oil. 62.7% because of hot water, 19.3% because of hot tea, 12% because of hot milk. Basically, children at the age of 10 months, 11 months, and 12 months try to put and throw everything. They are very curious at this age and try to explore everything. So it is very important to monitor their activities, particularly at this age. Basically, the mortality, morbidity depend upon the total body surface area involved, degree of burn, site of injury, nutritional status of the child, and any other comorbid. If we see in 106 cases, 39.6% had less than total body surface area involved, 40.6% had 10 to 19% total body surface area involved. So almost 80% children has less than 90% total body surface area affected. 6 infants had more than 40% or above burn. 1 infant had 80% burn, and 1 infant had more than 90% burn. In Middle Eastern countries, the mean total body surface area burn was 10% to 48%. While in the United States and Canada, 62% of all patients had less than 10% total body surface area affected. I had taken few photographs at that time after taking the permission of their parents. 8 months old child with history of falling hot water suffered 27% scare burn. If you see, there's an involvement of the head, some part of the face, trunk, and both the upper limb. Another child, 11 months old child with 29% scare burn. Very sick child, went into the sepsis, put on ventilative support. If you see, there's an involvement of the head, some part of face, anterior tongue, and both the upper limb. When we calculate the surface area in infants, the surface area of the head is 18%, trunk 40%, limb 16%, and lower limb 26%. As compared to the surface area of the infant, at the age of 3 years, the surface area of the head is 15%. At the age of 6 years, the surface area of the head is 12%. And above 12 years, the surface area of the head is 6%. So the infant had greater surface area of the head as compared to the other age group. Same child, after 4 months of treatment, looking well, but it still needs some cosmetic surgery of her left forearm. This is a recent photographs. This child was admitted 15 days back, 40 days old neonate with 19% fire burn. Basically, mother lit the candle at the side of the bed, and accidentally it fell down on the mattress, and the result is in front of you. There's an involvement of the whole face, eyes, and ears. For the prevention of the post-burn morbidity and mortality, multidisciplinary team is required, along with plastic surgery team and pediatrician. There is a very important role of physical therapist, occupational therapist, infectious disease doctor, and orthopedic. Here I would like to mention a few things which are very important for the management of these cases. Number 1, acute care and resuscitation. Resuscitation means fluid and electrolyte balance. We have to calculate the fluid according to the estimate percentage of the burn. Wound management is another very important part. Pain control is very important. Superficial second-degree burn is very painful. So it is very important to control the pain. Infection control especially hospital-acquired infection. Early nutrition. We have to give high carbohydrate diet and protein at the age of 9 months, 12 months, and 1 year. We have to maintain the hemoglobin level up to 10 gram per deciliter and serum albumin level to 2 gram per deciliter. We have to maintain the hemoglobin level at the age of 1 month up to 12 gram per deciliter. If the prothrombin time and partial thermoplastin time are prolonged, so we have to transfuse fresh frozen plasma. Reconstruction means we have to needs grafting. In the 3rd degree burn, students needs grafting, and sometimes 2nd degree deep burn needs grafting. Reconstructive surgeries of the different body parts may be required. Psychosocial adjustment is another very important part of the treatment. Another child with 23% scared burn. If we see the degree of the burn, 1st degree burn means there is an involvement of the epidermis. It is characterized by swelling, edema, and pain. Pain normally subsided within 24 to 72 hours. And there is slight peeling of the skin on 4th and 5th day. It is just like sunburn. There is no blister formation. In 2nd degree burn, there is an involvement of the dermis. It is superficial dermal and deep dermal. It is characterized by vesicles and the blister formation. 3rd degree burn means there is an involvement of the whole epidermis, dermis, and subcutaneous tissue, and there is no epithelial cells to repopulate. If we see in 106 cases, 70.8% had 2nd degree burn, 13% had 3rd degree burn, 16% had both 2nd and 3rd degree burn, 28.6% with fire burn had 2nd and 3rd degree burn as compared to 13% with the scared burn. Common site of the involvement, children with more than 10% burn should be admitted in the hospital for observation and treatment. But if there is an involvement of the hand, feet, perineum, genitalia, major joint surface, face, or 3rd degree burn, so these children should be admitted in the hospital whatever the percentage. Another important point, it is important to assess the pattern and the site of the injury and their consistency with the history. Child abuse and neglect must be considered if the history and the distribution of the burn do not match. Second, a patient with 1st and 2nd degree burn of less than 10% total body surface area may be treated on outpatient basis. But unless just the family support is just inadequate or there are issues of child neglect and issues, these children should be admitted in the hospital for the counseling of the parents. If you see in scared burn, common site of involvement is chest was 62.7%. Basically, the children try to pull things, so the upper part of the body is mainly affected. Multiple sites of the lower arm, 28%, followed by upper arm, face, head and neck. As compared to the fire burn, common sites of the involvement was lower arm, 47.6%, then chest wall, upper arm, and face, head and neck. Length of stay. As we know, the length of hospital stay has been observed to be an important measure of morbidity among trauma patients and has an influence on patient final outcome. Prolonged duration of hospital stay is related with unacceptable burden on hospital resources as well as increased cost of health care. In prolonged duration of hospital stay, there is an increased risk of hospital-acquired infections. Parents and families are worried regarding 2 things at the time of admission. Number 1, length of stay. 2nd, the finance required for the treatment. Mothers are gravely concerned regarding the length of stay because most of these infants are on breastfeeding. Sometimes it is very difficult for us to separate these small kids from their parents. Therefore, it is very important to determine the duration of stay in relation with the degree and the percentage of burn. It may not only have in the counseling of the family, but also have the hospital administration regarding the expenditures to be incurred. Because sometimes these patients are treated through welfare funds.
As far as our hospital is concerned, if the patient has financial issues, we have welfare office, which bear the cost of treatment. And sometimes it gives 100% free treatment, not only in burn cases, but in other specialties also. If we see, most of the infants stay between 1 to 10 days. 70% stay between 1 to 10 days, 16.9% stay between 11 to 20 days, 5.6% stay between 21 to 30 days, and 7.5% stay for more than 30 days. In Kuwait, the average length of stay was 16 days. In United States, the average length of stay was 8 days, while in Hong Kong, the average length of stay was 7.4 days. Length of stay in scattered burn in relation to total body surface area, total number was 83. Out of these, 32 infant had less than 10% total body surface area involved, and among these, 93% stay between 1 to 10 days. 34 infant had 10 to 19% total body surface area involved, and among these, 64.7% stay between 1 to 10 days. As compared to fire burn, 9 infant had 10% total body surface area involved, and 77.8% stay between 1 to 10 days. 8 infant had 10 to 19% total body surface area involved, and 50% stay between 1 to 10 days. So the duration of stay is slightly prolonged in fire burn as compared to the scare burn. If we see in relation with the degree of burn, it is almost the same in both scare burn and fire burn. But if the infant is having second and third degree fire burn, 66.6% stay for more than 20 days as compared to 27% infant with scare burn. If we see the outcome of 106 cases, 89.6% were discharged, 2% left against the medical advice, 8.5% were expired. Among these expiries, 66.6% expired because of scare burn, 33.3% expired because of fire burn. And most of these expiries occurred within 5 days, and most of them had 40% or above burn and having third degree burn. The mortality rate is similar to those reported in Turkey and China. However, it is higher than that reported in other countries. Follow-up. After discharge, infants were follow-up at regular interval for wound healing and to prevent hypertrophic scar formation. To ensure maximum cosmetic and functional outcome, occupational physical therapy must begin on day of admission, throughout hospitalization, and after discharge. Physical rehabilitation involves body and limb positioning, sprinting, exercises, active and passive movements of the joints, assistance of activity of daily living, and gradual amputation. These measures maintain adequate joint and muscle activity with as normal range of movement as possible after healing or reconstruction. Pressure therapy is necessary to reduce the hypertrophic scar formation. We have prefabricated and custom-made garments available for different body parts. We apply on that on the scars that reduces thickness, maturation, and itching. If we see, 2 infants require reconstructive and cosmetic facial surgery due to fire burn. 7.4% developed contractures for which reconstructive surgical procedures were done. We provided special care regarding the nutrition. Growth and development was monitored at the time of follow-up. Conclusion. Burn injury is an important public health concern and is associated with high morbidity and mortality. Infantile burn injuries can be decreased and prevented by educating parents through seminars, posters, and print media. In this aspect, electronic media can play an important role along with social welfare organization and housing department. These are few recommendations, but they are very important. We pediatricians can play a very important role in the prevention of these types of injury.
by educating the parents and by educating the healthcare providers. Take care while drinking hot liquids such as coffee and tea when holding an infant, and never be left at their disposal even for a minute. Always keep handle all pots and pan in the kitchen turned towards the back of the stove. This is very important. When your infant starts walking, extra care is required, not with hot water for bath or for any other reason. Prior check of the temperature of bath water is necessary before your child gets into the tub. Here I would like to mention a case of negligence. A month back, a 7-month-old child was admitted because of a scare burn. The incident was that the mother put the child in the sink for the bath and turned on the hot side of the tap. As you all know that hot water takes little time to come, she left the baby for correcting the clothes and towel. When she returned after a few minutes, that child was burning hot water. So these kinds of things should be avoided. Use cool humidifiers, not steam vaporizer. A vaporizer can cause severe burning if an infant overturned it or put his face close to it. This is another home practice to treat respiratory tract infection by using hot water in the container for the opening of the nostrils, which can be simply opened by normal saline nasal drops in the nostrils. So these kinds of things, these are very dangerous for small children. Electric sockets and open wires should be covered. Keep fire, matches, and lighter out of the reach of the children. Avoid smoking cigarette, especially in bed. Do not leave lit candles unattended. Thank you. As far as child abuse and neglect, basically most of these sometimes is because of negligence. As far in our cases, we have doubt about 4 or 5 cases of child abuse. We admitted these children in the hospital for the counseling of the family. But it's very difficult to find out if it's a child abuse or neglect, particularly at the age of 1 year. But most of the time, this is a case of negligence. Is what your second question?
What kind of resources you have to investigate these cases if there were child abuse or child neglect?
At the investigation at the age of, particularly at this age, it is we have a history, and the side of the is not matching. The history of history and the distribution of one is not matching, and there is a possibility of child abuse. So find out what is the problem, the psychological issues in the family, social family issues. So we try to solve these issues. Sometimes there's large family size, parents having 5 children, 6, 7 children. Sometimes it's a possibility.
Even we have some organizations who work for the child welfare, especially look for the cases like child abuse, child neglect. They work on these cases where there's a high degree of suspicion, and then they go and talk to the family, and they can even take the help of our law enforcement agencies. But it's extremely difficult, especially in children under 1 year.
Thank you very much. I think, excuse me, the last part of our presentation about reflexes is the most important. I vividly remember when I was in Karachi, we made a campaign in the villages regarding the prevention of spinal fever through supplement folic acid. Now, this is the same thing. It's not a matter of writing 1, 2 to 10. It's a matter of implementing it through the social media, not only every month, but should be every week. And by showing the pictures of those unfortunate children, the mothers will not move without this sort of line. The mother moves when they show sorts of outcome. So it is our responsibility not only to manage them when they come to us, but to prevent them from coming.
It's our responsibility to basically to education of the parents by showing some pictures of these kinds.
So how many percentage of your patients have medical complications like pre-renality and hospital-acquired pneumonia and septicemia? And how much intervention you need, like how much percentage of patients needing invasive support, like respiratory support, or dialysis, just one? No,
As far as hospital-acquired infection, in 106 cases, 28 infants develop hospital-acquired infections. And the most common organism that we have is Staph aureus. Second, in our
scenario in our setups, Acinetobacter is a major.
What about pre-renal AT and how much it was common among all these patients and how many percent?
It depends upon fluid resuscitation. We have to calculate the estimate amount of the fluid. If you give right amount of fluid to these babies, and child is passing 1 ml per kg of urine output per day, so there's chances that most of these children recovered. Sometimes a short period of acute renal failure, but not on the dialysis. No, no.
I have a question for you. Is there the need or the use for metabolic monitoring in burn patients?
Sorry?
Metabolic monitoring. I work in the pediatric burn unit at the University of Chicago, and so as part of nutrition management, we have a metabolic cart that we hook in line with the ventilator, and so it gives us VO2, VCO2, RQs and energy expenditures, and it helps us to determine if we're overfeeding or underfeeding patients.
As far as nutrition support, sometimes the oral intake is decreased. We arrange a parental nutrition, calculate the carries, daily serum proteins, electrolyte, and the nutrition care, give the supplements according to the reports of the conditions.
Right. Because I guess patients with thermal injuries, they just lay there in the bed and chew up calories. And so there was a big debate amongst them.
Especially in the children, we are very difficult to maintain the carries because they need high carbohydrate and protein diets and double the carries requirement at their age.
Okay. And one of the good things about this device is it's up and coming. And so it gives you measurements of oxygen consumption and energy expenditures. And so we were actually able to use it for pain management in patients who were deeply sedated. And so what happened was a patient who they were getting ready to do a dressing change on, and his VO2 shot up from 375 up to 800 milliliters per minute. His energy expenditures went from 3,000 calories up to 5,600. So we thought the machine was broke. And so we actually woke up and asked him, "Hey, Otis, are you awake?" He opened his eyes. "I'm awake." "Are you in pain?" He said, "Yes, I'm in pain." And so you can actually see how, when they put the sedation on board, how the, the numbers for the VO2 and energy expenditures drop back to pre-dressing change numbers. So that's something to look at in the future. Okay, we're about done with this session, so we would like to take a group picture of everyone.
Yeah, please, everyone get organized at the podium for a group photograph, please. Thank you.